So we've got lots and lots to cover today. I'm going to ask each of the panel to introduce themselves and to say a bit about what they're working on. I've got some questions, but there will be a chance for you to all ask questions, so please do have them ready. So, Nisha, can I come to you first?
Okay, so I'm Nisha Sharma. I'm a consultant breast radiologist and director of the breast screening programme for Leeds and Wakefield. So I've not had to travel far for this meeting, thankfully. So I'm a clinician full-time, but I'm also an innovator. So I'm keen to adopt technologies and also work with artificial intelligence that's going to improve the patient pathway. So I'm really in the thick of it in terms of the pressures. We're not meeting 2-week targets when it comes to women going to symptomatic breast service. I'm also working in the breast screening programme, which was developed in 1988. So I'm aware of dated pathways, I'm aware of dated software, and what my role is really to promote earlier diagnosis and how can I improve the patient pathway, but also improve the pathway for the clinicians delivering the service. Because what we've got to remember is we've got to also help them because we've got a workforce crisis. So in terms of artificial intelligence, I'm looking at image quality, I'm looking at the diagnostic setting, I'm looking at AI in the ultrasound setting, and breast density. So I'm working in different areas within the breast field.
Thanks, Jacob.
Morning, everyone. I got that wrong. Afternoon. Delighted to be here. Jacob West. I look after Microsoft's healthcare and life sciences business in the UK. Prior lives, NHS policymaker, frontline hospital manager, medical research. I've been at Microsoft nearly 5 years. It is all about AI now, so if you wanted an apology, you're not going to get one from me, sorry. But our wider business really is about AI solutions. It's about cloud, data and AI platforms, and it's about making that all secure. And I will talk about Copilot, among other things, but I will hand over to Imam in the meantime.
Hello, Imam Hoque. I'm a co-founder at a company called Quantexa. We are a London-based software firm, offices in Liverpool and all around the world. So just under 1,000 or so people, and we're focused on AI and big data and connecting data to enable your AI. So we work with 30 of the 50 largest banks in the world across the globe, large government departments, and what we tend to do is things like single view of customers for the banks, the analytics platforms, the AI that sits on top of that, letting people talk to their data, which you can now do with AI. And within government, things like single tax record for citizens and businesses and things like that. So joining up very large amounts of data. AI, it's been around a long time. I've been doing AI projects for a long time. In actual fact, I did my master's in AI in 1990 at Northwestern. So that is a very long time ago. So it's moved on a lot since then. And I think the key is all about working in partnership to unlock how you can use these things, because we have a lot of skills and our customers want to work with us and understand how they can transfer those skills from other sectors to achieve the outcomes they'd like to achieve.
Hi everyone, I'm Greaves. I'm Associate Director of Digital Transformation at Leeds Community Healthcare. Again, haven't travelled very far, 15 minutes journey this morning, luckily. I'm here, I'm passionate about digital transformation. I've worked in the NHS for 33 years now, 25 years in in digital transformation. There's been many changes over those years. There's been many buzzwords. I'm wondering whether AI is a buzzword or actually whether it's going to make some difference. So I'm sat on the fence a little bit at the minute, but hopefully I'll share my thoughts as we move forward. From a community healthcare perspective, I think we've felt a little bit like the poor relations in the system up to now, with the 3 shifts in the plan around hospital to home care, analog to digital. Feels like, from my perspective, my time is now. Lots of opportunities now. If we can't do it now, when will it happen? So very excited.
Thanks, all. I'm going to do a panel of 2 halves. The first is going to focus on the what and the why. So what is it and why are we doing this? And then a second a bit on how do we get this implemented. So first question for Nisha, really. As we've said, digital data really runs through the heart of the 10-year plan. But from a patient and a staff perspective, and we did have a chat about the pressures on staff just before we came in. What could it really mean? What transformation could we see?
I mean, I think it's good that it's in the 10-year plan, but for me, it's about creating efficiencies and data, communicating data from different registries, being able to have that data flow that can come to the clinicians, but then is also available to the patients. I mean, at the moment, we talk about us working in silos, but the data systems seem to be working in silo as well. So you have a national registry where you can record a woman's ethnicity, but we have to ask them their ethnicity when they come for breast screening because we don't have permission to use that information. So, there's a lot of repetition of data collection, there's inefficiency, and if data isn't readily available to us, then how do we know we're making the correct decisions for the patient? And if the patient doesn't have all the information or their family, then how do they know what choices that they have available to them and make the right decisions and decide where they want to go? So knowledge is power, and it gives us empowerment as clinicians, but also for the patients and their families to be empowered and restore, I think, confidence within the health service. Because often you'll hear it, the patients will say, "Don't you know that already?" And then it's awful because you've got to say, well, we don't have that information available to us, or we're not allowed to see that information. So I think that flow of information, I think, would be really important. But for me, it's about the registries communicating with one another so that we have one patient record that's complete, and therefore we create safe delivery of healthcare. And that will drive up confidence within the system as well. But the other part for me is about... we touched on it this morning, and we talked about innovation and how do we share good innovation. And I think that is lacking because, I am doing innovation in my department, but to get it to scale it is going to be a challenge, because how do I get visibility of the work that I've done? How do I get adoptability from different organisations? And how do we recognise that that's good clinical practice? Because we've got good algorithms out there. We know that they work. But what we've got is a lack of adoption, willingness to adopt because we're risk averse. And what we need to do is start thinking differently. And the other thing that I'd just like to add is the problem with innovation is we have a pathway. And we've just been told that the processes we've been using have been there since 1948. And for the breast screening programme, it's been there since 1988. But what do we do when we get innovation? We adapt it into the same pathway. We don't actually think, could we do this differently? So actually, let's scrap the current pathway. And now that we've got all these new technologies, all these new innovations, could we work differently? And that's why I think adoption is failing at pace, because we're trying to just keep going the way we are, and no one's got the headspace to think laterally.
Thanks, Nisha. Two things I just want to pick up on. One is around that efficiencies piece, and this is creating, we share data, we create more efficiencies, we can spread innovation, that feeds into the productivity agenda, doesn't it? We're being more productive. So, Jacob, to your point, 10-year plans, it mentions productivity 61 times. Could you talk a bit about what you're doing at Microsoft on productivity? And one of the things we talked about in our pre-meet, wasn't it? Well, what does productivity actually mean? So it'd be great to kind of have a few thoughts on that.
Of course, thanks, Laura. So 3 AI applications that are here and now that are productivity enhancing, and one that's in the post. So number 1, Copilot. Anyone heard of Copilot? Yeah, anyone using it? Okay, quite a few hands. So there are tens of thousands of people in the NHS using Copilot. Hopefully you are already seeing some value from that. NHS England's evaluation study of 10,000 users says that it saves 43 minutes per user per day. That's 2 days a month. That's nearly a month a year. That is a lot of productivity to give back to the NHS. How do you turn that into a cashable saving? That's for brighter minds than me to work out, but the opportunity is there. And that is just the out-of-the-box technology. Where that goes next, the kind of use cases that gets applied to that are clinically adjacent, it's not for direct clinical care, I think are really exciting. So that's the first one. The second one is Dragon Copilot, which we launched in the market this month. Sorry, it's 1st of October, last month, September. That is Microsoft's clinical AI assistant. It's not just ambient voice technology, it's a whole workflow. On average, that saves 5 minutes per clinical encounter. That would be about, if every GP used that, Copilot told me this morning, that would be over 500,000 hours per week back to the NHS. It won't be appropriate for every one of the 140 million outpatient appointments, but it will be appropriate for a large proportion of those. Think about that productivity opportunity. And that isn't just about, it's in part about clinical burnout or the avoidance of it. It's also about patient quality. How does the patient tell a fuller story? Eyes on the clinician. So it's technology in a way that takes away technology and enhances the patient experience, as well as increasing the efficiency of the service. So we're really excited about that. We've been trialing that technology with a number of trusts, including Manchester Foundation Trust, and looking to see how that starts to scale in the NHS. The third one is agents. We are living in the agentic era. So Satya, our global CEO, tells us that is about, so if Copilot is about personal productivity, if Dragon Copilot is about clinical productivity, agents are about automating processes. So how do you cut the drudgery from processes that don't need to be manual? So one example that's already real, in Blackpool, they are using an HR agent to turn a manual HR conversation, a manual HR process that would take £10, about 10 to 15 minutes per encounter, to something that would cost about 50 pence. If you start to scale that up, you start to think about the productivity opportunity across a whole series of functional areas. So those three are here and now happening, productivity enhancing in the NHS. The one in the post that I think is maybe even more exciting is if you start to put this technology in the hands of consumers, in our hands as patients. We've all back in the days of WebMD or Google search, people have started to inform themselves as a patient, but generative AI with that, low barrier to entry, that insane computing power that sits beneath it, starts to take it to another level. There is a big regulatory question that needs to be addressed there, but Microsoft AI, based out of London, is developing that kind of tooling and thinking about what could that mean to really, I think, completely shift the supply and demand curve, or the supply and demand equation in healthcare. So it's very exciting, I think, where that might go, but that's a little further down, I think. So hopefully that gave some ideas. Happy to carry on the conversation.
Thank you. Imam, Quantexa works across multiple sectors, so lots for us to learn from different industries. Can you talk about some of the kind of the wider work you've been involved in and what we could take away and bring into the NHS?
Sure. So if I look across whatever I've been doing across all these sectors, I think there's one theme that's pretty common. Everyone is very data rich, but information/intelligence poor. So what that means is they have armies of data scientists and others trying to bring the data together, trying to get some insight out of it so they can make better decisions. That's fundamentally what they're trying to do, whether you're a bank, an insurer, a tax department, whatever it might be. So the question is, how can you reduce the effort involved in that? And that's the work we've been doing across all of these different sectors. So AI's been around a long time, but the critical element is getting context in that underlying data. You can't just look at one piece of data in isolation and say, I can make a decision. In a bank, it might be, is this transaction money laundering? You've no idea. You've got to know where's it going from, where's it going to, what are those companies, who are those directors, what they might be connected to. So if you can build the context, for which you have to solve a very hard problem, which is a single view of the person or the business. Not everyone has an NHS number in all the data that's relevant. So, schooling data, social care data may be interesting, might not have an NHS number. So join the data up, and then you can start using the analytical capabilities. Now, as we've just heard, the latest round of AI is doing something which is empowering people to literally talk to their data. And that's what we've been providing to these large organizations. You can just ask questions of your data. You don't have to go to a data scientist, request the data, get a bunch of work done. And then you can take that further because the data can start alerting you. Is there a problem here? Is there a hotspot here? So that's been a key understanding within those sectors. Now, how does that translate into healthcare? We're currently doing a pilot at Cheshire and Merseyside, which is all around vulnerable children. So if a child goes into A&E, they might have a broken arm, they may be in another A&E 2 weeks later with bruising. Is there an underlying issue? So if you could generate context in the data by joining up social care, mental health, community data, you may understand the household risks involved, whether there's, I don't know, some sort of domestic violence, alcoholism, or whatever it might be in that context, so that the person that's treating the child at that point can immediately see what's going on. And that's where the data is allowing you to get a full picture very quickly. And there's many, many scenarios around joining up primary care, secondary care, and other types of data. So the next phases of that project, in an ideal world, you will get education data, you would get more data from people like policing and others that is relevant to that. So we have to unlock that. And really, the AI and the capability that sits on top of this context is what lets people make better decisions faster with less effort. And that's probably the key lesson that I've seen. Obviously, there's lots of other things in AI. There's all the radiography, image processing, etc. But underlying data gives you a huge amount of value if you can join it up.
Fantastic, thank you. I'm really glad you picked up context and what that data tells us about individuals and what it means, because that segues nicely into the question we're going to ask Dawn, which is around community. Community is where life happens, isn't it? It's where we intersect with kind of home and health. And, you know, with neighbourhoods and community really highlighted in the 10-year plan, could you say a little bit about what can it mean? What are the opportunities in a often neglected part of the NHS?
So I want to tell you a little bit about our home first approach that we've got going on across the Leeds city. So it's a single piece of work happening across all the partners in Leeds. We started this over 2 years ago, so it's not a new thing that's come as part of the 10-year plan. It's already a priority that we knew we had to focus on. So as part of that work, physically what it meant is bringing people into a single room to work together. So we have social care teams, community teams based in the hospital, looking at how we can get those people out of bed, back into their own home to recover well. That's the aim of what we want to do, get people out as early as possible. So physically, we've been doing that work for quite some time, but it was a pilot. You know, we don't like pilots, where are we taking it next? We needed to think about what are the enabling functions that will allow us to scale that out across the whole city. So one of the things that came out of that was the need for a single care plan. So it doesn't matter who's treating that person, who's delivering the care, we're going to have one care plan so everybody knows what's going on. So I was brought into the SRO for that work, and we just went live in May with a single care plan. So we believe it's one of the first ones across the whole country to bring social care and community services together to work on a single system. Don't quote me on that. But what that's done is it allowed us to implement a single triage model. So we're doing one triage rather than two separate ones. It's happening quicker, so we know that the patient's getting the right level of care first time, not having to go out multiple visits. We've got the right level of people going out to treat them, so we've not got wasted visits as well. So it's made the whole system really much more efficient. The people that are going out into the homes have got all the information that they need because it's in that single care plan. So it's more efficient from a clinician's perspective. Patients aren't having to regurgitate the information over and over again. But where we were previously is community had their own system. Social care were writing on paper in someone's house. So that information isn't going anywhere. It's always there, but it's not easy to digest in that format when you're used to working digitally. But bringing the social care teams on that journey was a challenge. So they didn't have devices. A lot of them didn't have the skills to use the device, even if we were to give them one. The EPR that we use in community is not the easiest system to learn. It's not intuitive. So we had to spend a lot of time bringing those 150 staff on board with using technology, owning a device. What does that mean? How do I charge it? How do I make sure I've got connectivity? Before I've even got into the care plan. So a whole journey that we've been through to get to this point. We didn't get the training right either. So I think we thought e-learning was going to be great. Everybody doesn't learn that way. So we're now having to revisit quite a bit since we've gone live. The go live support was intense, much more than we thought we'd have to do, because these people aren't based in an office. You can't just place someone to offer support to these people. You've got to think about other ways of doing that. So we've learned a lot, but we are now scaling that out to other areas of the city. So it is bringing us some real good impact. Now, that's not innovation. It's doing something better with what we've already got. But how could we transform that journey with AI on top? So I was I was at an event last week where there was a gentleman from social care talking about connected care. What difference could it make if we had better connected data like we've just spoke about? And I heard a use case around a gentleman with Down syndrome, always lived with his parents but wanted to be independent. So just recently moved into shared accommodation with some other young teenagers that were learning together. He had a history of setting fires. Social care knew that, had it recorded as a flag on their system, but no other partners knew about that. So at the point where he sets his house on fire, it raised a big alarm bells. Had the fire brigade known that was an issue, they could have put some precautions in place, so thinking about that preventative method. We're just not there in terms of connected care. So whilst we talk a lot about health and care and bringing that together, it's not just those two partners, it's the whole system that need connecting up. So we work a lot with third sector organisations across Leeds, but we don't have their data and they don't have ours. They don't know what's going on, but the system could be so much better. Is that connected data or is it AI? What could AI offer on top of that to make it more efficient? There's much more around how do we prevent some of these things that we know is going to happen. We're also looking at a tech-enabled care model across Leeds. So at the moment, you could be in hospital, go home on a virtual ward with a set of technology so we can monitor you to see what's happening. Social care might have given you some technology because it's part of your normal preventative measures. And in community care, we're also starting to think about virtual wards. 3 pieces of technology someone might interact with in a short space of time. How do they understand how to use it? Who do they speak to when there's a problem with it? The whole system is flawed to start with. So we're looking at if we had one central database of what materials are available, what technology people might need, give them it once, give them one contact centre, but as long as all the partners that are interacting with them can see that data, that's where we need to be. So we're just going to start a pilot in falls prevention. So it's early days, but real opportunities. I think from an AI perspective, some of that technology is going to be really important for what we need to do and drive those efficiencies across the system. So not just for health, for everybody.
Thank you so much. All really compelling cases or opportunities for how we can use digital and AI. But we know tech and the digital pieces are just one part of the solution, aren't they? We really want to understand how do we implement them, how do we get them taken up and sustained and rolled out. So I guess the next kind of question set really is around what are the conditions for us being able to really optimize and make the most of the digital and the AI opportunities that present themselves. So in no particular order, would anyone like to kind of talk about what needs to be in place? What are the enablers that enable this?
Yeah, I think I have a bit of a mantra, which has always worked well on projects that I've done, which is innovate, pilot, and adopt. Sounds simple, but there's a lot of traps along the way if you don't get it right. The right way to do it is to find the innovator. So I can give you loads of examples. I'll give you one example, which is roll-on, roll-off ferries. So the task there is trucks turn up at Calais. You have half an hour to work out which truck do you stop at Dover. Could be contraband, could be drugs, could be human trafficking, whatever it might be. And we put an AI system in. This is 20 years ago, and statistically, it was probably a bit better than how the inspectors were doing their guesswork. But do you think it ever got adopted? No. So what we did was then went back and got the innovator, who we were then going to amplify out to all of his colleagues. So he worked with us and told us what to do, which sorts of models, because everyone thinks AI is going to work it out for itself. It won't. There's 101 things that you guys out here all know that AI will never learn on its own, so you need to help it. So AI is there to amplify and take what you do and repeat it. So this guy gave us all the different scenarios. He said, if a truck goes across and a foot passenger goes across at the same time who's a tourist, and it happens again and again, stop the truck. And we said, well, why would we do that? So that foot passenger is a minder. It means there's drugs on the truck. So these insights don't come from AI itself. But then we could do stuff that people can't do quickly. We could scan all the company's house records, see which logistics firms had previously had their husband or wife have a company where there were contraband stopped. So this type of capability and getting that innovator to then go out to all of his colleagues and say, this system's going to be great. You should adopt it. It's really going to work well, because he was involved with it. So innovators help adoption, and piloting is the way you prove the point or the business case. And that time and time again, whether it's banks, tax authorities, border control, whatever it is, that's the way projects get successful.
Thank you.
Well, I was going to say, I think this is quite an exciting time for us in terms of adopting new innovations in artificial intelligence within the NHS, because it might mean that we'll all have better IT systems and infrastructures in place, because currently we're not all at the same benchmark. So even if a company was to come to us and we were to deploy an algorithm, you'd probably find that you're not on the right version of the PAC system. If you're using imaging, you might not be on the right version for Windows. So the thing is, our basics are not there. And the assumption is that we're all working at the same level, and we're not. So I think innovation might allow us at speed to get to the same level. So I think we should embrace that and not see that as a negativity, because if people feel that this is a priority, they will invest. And so that could be investment in our IT infrastructure. So I think that's really important. And the second thing is, I think we have to challenge. Now, if I go back to the breast screening programme, we have National Breast Screening System, which was developed in 1988. It's been agreed that it needs to be modernised, and I've been waiting for 15 years for it to be modernised, and I've now got a timescale of another 5 years. And my question is why? Because when pandemic hit, overnight, we went to having to have face-to-face meetings to be able to doing everything online and virtually, and we were able to create that connectivity. So I do feel that this is our opportunity now to challenge and ask why, when the technology exists, is it taking so long for it to be delivered where we need it in the front line? And it's really exciting to hear about intelligent use of AI, looking at data and collecting it, and what we've been doing in Leeds. But my question is, why aren't we speaking to companies that have that software in place that could actually help us get there much quicker? So instead of doing a 6-month or 1 year or 18-month pilot, why aren't we going out speaking to companies who have that technology, say, this is what we want to do, can we actually do it within 3 months?
Excellent, thank you. I think that's a great call to action, isn't it? If we can see things are working, why aren't we being more demanding of the system? Thank you.
Thanks, Nisha. Yeah, I love that, Nisha. I think just to reinforce an example that you alluded to, so let's not beat ourselves up. The NHS can adopt technology very rapidly under conditions maybe of expediency. The sort of rollout of Teams in the early weeks of the pandemic is a terrific example of that, and now it's ubiquitous. If you've got a problem with your Teams, talk to me afterwards, or don't. But I think in the era of AI, we have both new opportunities to think about technology adoption and some new challenges, I suppose. So just maybe to reinforce another point Nisha made, often the argument goes, well, I can't implement AI because I haven't got the basics right. Well, turn that round, like get your organization AI ready, and sometimes that will be the way in which you can convince the CEO or the CFO that they need to invest into the basic infrastructure, as opposed to arguing it for its own terms or because it's a cybersecurity risk, unfortunately. So that's one, I think, domain area. The second area where there's some new challenges is around trust and governance. So AI can be a black box. It benefits from explainability. Microsoft have introduced something called the responsible AI approach with an AI dashboard that helps do exactly that. So we've done work with organizations like Northumbria on their predictive AI risk score for orthopedic surgery that help clinicians explain to patients what that technology means in practice. And then in terms of adoption, adoption can't be top down or just bottom up. It's got to be sort of multifaceted, and some of the best the most effective ways in which we're seeing AI being adopted is peer-to-peer learning, peer-to-peer sharing. So we're running things called co-pilot cafes, which are getting sort of 1,000+ attendees across the NHS. And because this is a new technology, it's actually users at the bleeding edge of this, talking to other users about the prompts they're using or the use cases that are most valuable to them, that is really driving adoption. And frankly, when you hear people saying, never take this technology away from me, that this is an adoption curve that's going to grow and grow.
Thank you, and Dawn.
bringing it down a tone, probably. We talked earlier about risk appetite. The NHS is not great from that perspective. So I think there's something about how we do it safely. We keep hearing we can't use these technologies for clinical content, for confidential content, but we need to change that model. It's got to work for that. That's where the efficiencies are going to come. I think it's also something about how we understand what are the use cases that really are going to benefit from this. We did some work across our trust, engaging with every single service to find out who would want to use ambient voice technology. Just that, nothing else. They all wanted it. But when you look at their processes, it won't work. The EPR system that we use is not set up to work that way. There's lots of tick boxes, checklists. It won't work, or it won't bring them the efficiencies that they're expecting. So we need to enable people to understand what the tools are going to offer, what benefits they're going to get in different contexts. I think when you look at a lot of the innovations that come out, they're quite focused on acute care because pressure points are in the hospitals, but unless we get the community services right, the pressure points are always going to be in the hospitals. So we do need to think about what technology works in community services to help patients be better. And I think that's the landscape just needs to change. I think we need to get more people thinking about community services and what the opportunities are there. I think it's a real untapped market at the moment. Hint, hint.
Excellent, thank you. So I'm going to turn to the audience now. It's your opportunity to ask some questions. We have got a microphone, so please raise hands. So the lady there, the microphone's just coming.
Thank you very much. I just wanted to pick up on Nisha's point in the sense that you've waited so long for some technology, and then you've now been told you've got to wait another 5 years, and what's the barrier to adoption? I wonder whether some of the barrier to adoption actually is not the clinicians or the staff that are working with the patients, it's actually the IT teams within the hospitals and the networks. I'm from industry, and we often find actually they're the blockers to be able for us to move things forward, because to your point, they're very risk averse. How can we break that down and get the IT departments and IT infrastructure that you've got to understand how important it is and to work with industry to enable us to help you?
So, I think that that's a very valid point. And I think one of the problems that you face within the trust is the governance side of things. I think if your information governance and data protection team understand what the ask is from a clinical perspective, they can often say that this is doable. But it's the people that don't have the knowledge that end up being the barriers because they're risk averse. And often what I found with the AI work that I've done, I've had to knock on lots of doors to eventually find the right people that actually understand what I'm trying to do, instead of the knee-jerk response saying, no, that's too difficult. And as a result, I've found those enablers within my own organisation where I can set up projects within months rather than years, because I know the right people to speak to. And also, I think you make assumptions that people understand, and we have to stop making those assumptions. If you can't get your point across, you're obviously using language that they don't understand, or they don't understand clinically why it's relevant. So you have to change your narrative for them to understand why this is important for the clinicians or for the patients or for the service as a whole. So I've learned that over a period of time, but you do have to knock on lots of doors. But the other apart from it being at a local level, I think at a national level, there's a lack of expertise as well. And there may not be enough people working on the projects to be able to deliver at pace. And we've also seen a turnover of staff. So often you'll find that you've worked with somebody at the beginning of the year, and by the end of the year, they've moved on, and you're working with somebody new. So the problem with the National Breast Screening System is the DTOS, that's at a national level and not at a local level. So I think there are multiple barriers at different levels. So it's not just at the trust level. I think nationally there are barriers for deployment and speed of adoption, which I think we need to rectify, because I do think there's a big disconnect. The vision of AI and healthcare, we all get that is our future, but they're not realising there's a black hole in the middle. and we need to fill that gap for success.
If I can just come in on that one as well, I think there's so many standards we've got to follow in the NHS, it's a minefield. I was speaking to a tech innovator last week and who'd said it'd taken him 18 months just to get through the NHS process of digital safety. That's something we need. So as innovators, it's almost how do you get through that as quickly as possible? Coming to us with that completed, the risk is not as high, but it's how do we make that process easier for you guys, and that can only come from national. It's not an organisational level. I think quite recently on the ambient voice technology, lots of organisations have started trialling different product, and then NHS England gave us a mandate to say you can only use ones that meet the DTAC standards. I think it left us with one. You know, we've got to make sure that we're following those standards, but making it easier for organisations, I think.
Excellent. We've got time for one more question. Now's the time. Gentleman here.
It's more of an observation, really. So I'm Duncan Pearce from North Point. We're a mental health charity working across the region. And I think there's, what I'm hearing today is that there's an awful lot of work that's happening kind of in the innovation. There's a lot of work that's happening in the innovation space, linking in with the NHS. But when we talk, and Dawn just made a really good point about, you know, taking things out into the community, the third sector do an awful lot of work and do an awful lot of services across the community and work with the NHS in really, really strong partnerships. It's just an observation and probably a plea, really. I think we need to consider how we're developing the capability of that sector to be able to help in some of these areas as we move forward. So it was just a sort of an observation, but I think, you know, there's a responsibility, otherwise we're missing an opportunity that we will rely on when we're trying to do the shift that everybody's talking about.
Thank you. Does anyone want to respond to?
I think that's a really good point, and obviously we work really closely with North Point. I've got some great partnerships there. They're delivering care on our behalf. They're a vital partner, but we have limited data sharing between our organisations, and that's part of the puzzle that we need to fix.
Thanks for raising that. It's such an important point. Thank you. That brings us to the end of the panel. So a huge thank you to our panellists.